Well, it's a pleasure to be here. So for the next 15 minutes, I'll tell you everything I know about FHIR. And if I can go fast enough, we'll have some time for some questions at the end. But I wanted to start off by explaining why a physician would get himself mixed up in healthcare IT standards. And so I wanted to tell you a little story about Jack. Jack was actually a patient of mine. This is Jack, a remarkable young man, many talents, and really a pleasure to meet. Jack had knee pain. Had it more than 6 months before anyone actually did anything about it. This is what his knee x-ray looked like. So for those of you who aren't clinicians, all of that big white stuff in the middle is supposed to be the knee. When I saw Jack, this is what his chest x-ray looked like. That big golf ball size white spot in the right part of the lung isn't supposed to be there. Even if you're not a pathologist, you know that metastatic anything isn't good. Osteosarcoma is a tumor of the bone. In the United States, where we keep track of things like this, medical errors are the third leading cause of death. In the European Union, there are some estimates that medical errors disable permanently more than 250,000 citizens and account for more than 100,000 deaths. We make a big fuss when a half a dozen people are killed in a train wreck, and we're talking about hundreds of thousands a year throughout the world, avoidable medical errors. So this is my plea to end the stories like this. 7 years ago, I started a project called Fresh Look at HL7. HL7 had been getting stodgier and stuffier over its 30 years existence, and Fresh Look said, well, what if we could erase all those years and find a new paradigm with which to operate? And one of the key tenets to that is when you get a lot of engineers in the room with binary thinking, it's either 0 or 1, then there's a real challenge to get it perfect, to get it just right. So FHIR said, well, we're going to operate on the rule of 80-20. FHIR is really a nifty acronym, and in English there are dozens or hundreds, I've heard to this point, of the puns and wordplay using the concept of FHIR, but it really means fast healthcare interoperability resources. It didn't happen magically. It happened because HL7 had created a network of solutions that were complex, hard to understand, and difficult to implement. With FHIR, we changed the way we viewed healthcare data interoperability, because FHIR was created for the people not who made the standards, but who had to implement them. More importantly, FHIR plays very nicely with the dozens of other HL7 standards, which really exchange about half the healthcare data in the world, and with the other standards developed in organizations that play an instrumental part in making that happen. FHIR's development is really around the world. So the product director for FHIR is in Australia, and some of the leading developers are here in Europe, particularly the Netherlands and the UK. We give away FHIR like all the other HL7 specifications, intellectual property, and part of the democratic approach to FHIR is that we don't have an author, we don't have anyone who claims to be the grandfather of this standard. FHIR works because it's so easy to learn. In fact, while we are challenged in the number of languages we speak. We do teach the kind of programming in high school that's necessary to make FHIR work. So the typical development cycle is weeks to just hours. And so some really important FHIR applications have been developed in a very short time frame. I think part of the reason it's been accepted so readily around the world is a maturity model. So for each resource, we actually identify in what country it's used, whether it's implemented in a active program, whether there are hundreds of thousands, or millions of people being served by that resource. FHIR is based on application programming interfaces. A lot of times it's difficult to understand what that means, but the airline industry has it figured out. So if you want to fly from London to Athens, you put it in a search engine like Travelocity, and lo and behold, 20 different airlines will pop up, all the routes, the times, the schedules, the cost, and it's all because the airline industry has agreed upon an application programming interface. You don't see the algorithms behind their pricing, but you do see what the price is. And so regardless of what health system you may work in, what kind of data you want to share, we can exchange it with a lot of the same ease with which travel data is shared. At the heart of this is collaboration, and we think it's one of the fundamental principles. So if it's with another government agency, another standards development organization, whether it's with the World Health Organization or SNOMED, we have a working model whereby this kind of information is readily exchanged. In order to make this really easy, we created a FHIR Foundation. It was built with the implementers in mind, the people who had to use FHIR to make it work. So all the standards are there free. There's a sandbox, there are implementation guides, there are reference data, they're publicly available, and they're used without royalty or without charge. This is a nice extension of a Greek, I'll call it mythology. The Argonauts helped Jason get the gold fleece, but in fact, there was a project in the U.S. called JSON, and JSON said, what if you really needed to get data amongst all the disparate health systems? How would you do it? And they came up with the notion of open application programming interfaces. The Argonaut project was formed to accelerate the implementation of FHIR. We partnered in a really seamless collaboration with Harvard Medical School and Boston Children's. They had a 6-year project called SMART about building applications, and FHIR fell neatly into that paradigm. And since then, Smart on FHIR has created a world of applications. There are now thousands of them that are used worldwide to change patient data, clinical research, and precision medicine. And in the U.S., it's used widely in public health and even in the insurance industry. There's an application gallery. It's freely accessible. You can download these applications, their connections, whether from Smart Health or from the HL7 FHIR Foundation. There's a unique program around clinical decision support. I consider clinical decision support the sine qua non of electronic medical record. You can always find ways to archive data, but if you're at the point of care, you need to have real-world evidence before you make a decision. It was only a decade ago that the average clinician needed 5 data elements to make a decision. By the end of the next decade, it'll be 500 elements. No human can consume that and expect to have evidence-based care. So clinical decision support is really key, and CDS Hooks enables that. We'll try that one. 4 years ago, we created a partnership in interoperability. It was really exciting because a host of people who needed the data said, you know, we have a lot in common. There are too many disparities between what the research community and the value-based care community, what public health and community services need, what behavioral medicine and oncology needs. And this partnership served as a meeting place. Our next partners meeting is in New Orleans next month. Also have a lot of partnerships from the tech industry who are using FHIR to leverage their enormous capabilities, whether it's the Apple Health Kit or the IBM Watson program. Getting clinical data out of a medical record has really been eased by orders of magnitude by the implementation of the FHIR platform. Within the U.S., there's hardly an agency that doesn't use it, and excitingly, there's now been a recognition of the value of FHIR by the European Medicine Agency, which is using FHIR in real-world clinical trials. No longer will we be stifled with the untenable 50% success rate in most drugs that manage to clear regulatory approval, and we'll be looking at the way patients behave, the way doctors prescribe, and the way regulatory agencies define what's safe and effective. The biggest ship that's hard to turn is the biopharma industry. They're notorious for having a giant ship that changes only a degree at a time. Well, we've now partnered with 25 of the world's biggest biopharma, and they're in a pre-competitive environment trying to use FHIR not only to get clinical data, but to make sense of the clinical trial legacy. Perhaps one of the most exciting areas is integrating genomic data. No longer will we give the same dose of the same drug to people of different ages and sizes and genetic makeup. These are 4 or 5 different programs which use FHIR to integrate genomic, genetic, proteomic, and even metabolic data directly into the electronic health record, not just for translational medicine, but also for patient care. Lastly, we have a program, Devices on FHIR, where the international device manufacturers have recognized that you can get data out, and like the last speaker, she talked about the incompatibility of the different data streams. FHIR is a great democratizer because through FHIR, all of these tools, whether it's a pacemaker or a ventilator in the hospital, whether it's a Fitbit on your wrist or some other patient-centric device, they can all report to the same database. Clinicians are a big part of this, whether physicians or nurses, pharmacists, or other people in the care continuum. Our next meeting will be in New Orleans in February. Over 400 organizations have now agreed to support the FHIR implementation program, whether they're small startups or big international technology developers. I think part of the excitement is around managing the rate at which the adoption and implementation take place. The CDC, the Center for Disease Control, certainly has a legacy of horrible disease management process. There are 3,000 public health agencies in the United States, and 1,500 of them send paper reports to the CDC in Atlanta. Google figures out when there's a flu epidemic faster than the U.S. CDC. I think lastly, I'm delighted to tell you about a program in Amsterdam in November in which both the business case, the process, and I think more importantly, some of the technical developments around FHIR will be taught and discussed in a really open forum. We'll reprise that in Boston in the summer. We're going to showcase a lot of the FHIR development work in New Orleans in the beginning of December, and I just recommend a roadmap to many of you, some of whom are very familiar with FHIR and others who are less so. And this roadmap, which we've kept pretty close to the vest, will now lay out at least where we're going for the next 15 months. So with that, thank you for your time. I appreciate it. And have I left a moment for Q&A? I'm glad to take a question or two from the audience about this program or anything else. If I've explained it to you all, then great. So this is my email address. If there are any questions, and certainly this presentation and copies of this will be available from this website. But I think more importantly is the excitement that the international community has shown in making this work not as a local project, but as a truly international one. So thank you.